Hello friends, welcome back to my channel. I hope you all are studying well. Today we'll be discussing the various respiratory diseases which you may encounter in your patients, and they are very important from exam point of view. I'll be discussing the various respiratory diseases which can be seen in your patients or the clinical scenarios which you will get in the exam, their pathology, their clinical features, their little bit about their treatment as well. So, this is all what we'll be discussing today. In the second part, which I'll be posting soon, I'll be discussing the dental management of these patients, how our treatment plan should be modified in each of these diseases. But before going ahead, can I please ask you to subscribe to this channel and click the bell button? Let's get started. In the beginning of the video, can I please ask you to excuse me because this is going to be a bit longer video because I wanted to cover all the diseases and I hope this will be really helpful for you. So let's start with asthma. It is a common obstructive airway disease characterized by reversible airway narrowing. So what is most important word here is, from your exam point of view, it is that it is reversible airway narrowing. And it occurs because of the bronchial mucosal inflammation, mucus, and smooth muscle contraction, which is caused by the allergy or precipitating factors. Means there is some precipitating factor or some allergy which leads to the bronchial mucosal inflammation. So there occurs the inflammation of the bronchial mucosa. The mucus is secreted and the smooth muscles they contract and hence leads to the obstruction of the airway. It is presented as with the episodic dyspnea. There is dyspnea, there is wheezing, and there is cough. Wheezing is most important here, and it is episodic in nature. The symptoms they are worse in the early morning. Another important thing when in the scenario you'll be asked said that it occurs in the early morning, so we should think of asthma. And the severe attacks they can be life threatening, so it really needs some treatment. Patient also gives us the history of previous hospitalizations, and this leads to risk assessment. We need to do risk assessment for each and every patient with a medical condition. And how can we do the risk assessment in the asthmatic patient? It is by the previous history of previous hospitalizations for the attack. Patient can tell us how severe the attack was. Did patient need any hospitalization or not? As well as the patient's medication, because the medication of asthma it varies in the different from mild allergy, mild asthmatic patient is given just inhaled bronchodilators, or and as it progresses towards the severity the combination of various drugs they are given. So from these things we can know about the risk of patient. Peak expiratory flow rate, that is PEFR, it is impaired. This is again important thing. So the PEFR it is impaired, but usually it improves with the use of bronchodilators, which is given as the treatment and between the exacerbations. So when we ask or we find the PEFR, so that will be impaired during the attack, but it usually improves with the use of medicine as well as the exacerbation. So this is about asthma. Next is COPD. COPD is another important disease of the respiratory system. It's common, chronic, and non-reversible. So this is chronic as well as this is non-reversible, narrowing of the airways. It includes two diseases. First is chronic bronchitis, which is narrowed airways, and chronic productive cough. If the patient comes and says that patient he has been having the productive cough from a long period of time, then you should think of COPD along with few other things which we'll be discussing now. Another COPD disease which is included in COPD is as emphysema. Emphysema, what happens here is there is destruction of the alveolar walls with enlarged distal air spaces for gas exchange. So what happens here is the gaseous exchange which occurs in the terminal side, distal side of the alveoli. Okay, so the damage or destruction it occurs at that point. I hope I'm making sense. How does this present? The presenting is very similar to that of asthma. That is why I said that we need to be very careful in distinguishing these. But the cough is different. The cough is characteristically more productive in COPD and PEFR. We said it there. And here the PEFR shows little or no improvement between the exacerbations. So this is the distinguishing feature if we have to distinguish it from or differentially diagnose it from asthma. COPD usually results from chronic smoking, so patient will give the history of smoking. Some patients with COPD they compensate by hyperventilating. So when the patient hyperventilates, they are called pink puffers. Okay, keeping blood CO2 levels down within the normal range. And this leads to type 1 respiratory failure. We'll be discussing it later as well. And other patients of COPD, they do not appear breathless, but presents with hypercapnia. So in hypercapnia, what happens is chronically increased CO2 is there, which leads to type 2 respiratory failure. Cyanosis occurs, blue bloaters, and right heart failure. That's core pulmonary. So this happens in type 2 respiratory failure. These are few important things. I may be a little fast, so I'll suggest to pause the video and read it again because this is really going to be helpful in the clinical scenario questions. What treatment do we give in COPD? So first and foremost is smoking cessation. Of course, we ask the patient to stop smoking. Then bronchodilators, usually nebulizers are used. Systemic corticosteroids, chest physiotherapy. Antibiotics can be given. Exacerbations are usually caused by chest infections. So whenever infection is thought of, then we give antibiotics. Oxygen administration is given, but hypoxia must be corrected with great care. Start with a low concentration and monitor arterial blood gases. This is very important thing. So I hope asthma and COPD is clear the differences between two and the clinical presentation. Next disease which we'll be discussing is pneumonia. Lower respiratory tract infection. It is often caused by viral diseases initially, but secondarily it gets infected by the bacteria and causes pneumonia. So this may be localized. When localized, it may be called it is called lobar, or it may be diffused where it's called bronchopneumonia. What is its presentation? The patient presents with the fever, malaise, dyspnea, productive cough, chest pain, as well as confusion. The pneumonia it has high mortality rate, especially in the elderly and those with the various underlying diseases which depresses the immune systems. The most common cause of community acquired pneumonia is Streptococcus pneumoniae. You may be asked this question. Streptococcus pneumoniae or pneumococcus is the most common cause of community acquired pneumonia. While the hospital acquired pneumonia, it is caused by gram negative bacteria like Klebsiella, Pseudomonas, or staph. Okay. Inhalation of teeth or tooth fragments or infected material from the mouth may cause pneumonia, lung abscess, and sometimes may lead to septicemia. So, this is very important for us as dentists to take precaution and prevent the inhalation or aspiration of teeth or any other material. In the elderly inpatients, with the sudden onset of pyrexia and confusion, even without the chest symptoms, even if chest symptoms are not there and there is sudden pyrexia and confusion, pneumonia should be suspected and chest should be carefully examined. Chest x ray and sputum and blood cultures must be performed. Empirical treatment must be started, if possible, after the discussion with the microbiologist, of course, which antibiotics we need to give. That's always beneficial. The patient will also need to rehydrate. Rehydration, oxygen, and analgesia are other treatments, supportive treatments, which we need to give. Next is cystic fibrosis. So, one of the most common autosomal recessive disorders in Caucasians is cystic fibrosis. How is it caused? It's caused by the mutation of CFTR, that's cystic fibrosis transmembrane conductance regulator gene. So there is mutation in the gene which results in defective chloride channel. Now, because this chloride channel is defective, so this leads to reduced salt and water excretion and therefore secretions they get thickened. which means that there is reduced airway clearance and predisposition to infection. I hope I'm making sense. So the gene is affected, which lead to defective chloride channel, which leads to then water reduced salt and water secretions they taken, they are not cleared away, so there is reduced airway clearance, and finally there is predisposition to the infections. Other exocrine glands like pancreas, salivary glands, they are also impaired in cystic fibrosis, and failure to thrive because of the pancreatic insufficiency as well as malabsorption, diabetes, and recurrent chest infections are the important features in this disease. And because of all these things, so much is happening. So there is reduced life expectancy of approximate almost 30 years. Next disease is bronchiectasis. This disease is characterized by infected bronchioles and permanently dilated airways caused by severe chronic and recurrent lung infections. So there is infected bronchioles and there is permanently dilated airways they have been permanently dilated, which may be because of severe chronic lung infections. There is persistent cough and purulent sputum follow. So this is bronchiectasis. Next disease is obstructive sleep apnea, OSA. This is another important disease. It is relatively common, so do expect any clinical scenario in your exam. So it's characterized by the narrowing of the upper airways during sleep, which leads to loud snoring, episodes of recurrent apnea, and hypoxia, which wake the patient. So patient will complain you of that patient wakes up in the night, or the patient it is sleeping during the day. So that is, so typically it affects a middle-aged overweight men who complain of daytime sleepiness. All right. So at that time, we just want to be sure if the patient snores during the sleep, and this disease is diagnosed like this. Occasionally, nasal and pharyngeal pathology may be present and is usually surgically corrected. Weight reduction and avoidance of respiratory depressants, for example, alcohol, they are helpful. So we should advise the patient for go for the weight reduction as well as avoid any such depressants. Next is pulmonary embolism. It usually arises from DVT, deep vein thrombosis. When the patient is immobilized for a longer period of time, then DVT may occur and it may cause pulmonary embolism. It presents with acute dyspnea, pleuritic pain, fever, cyanosis, reduced BP, as well as ECG changes. All right. Mortality is really high, so we should be really considerate and we should be really thinking of this thing if patient is immobilized for a longer time. It is a medical emergency and needs to be treated immediately. Anticoagulation and 100% oxygen should be started immediately. Next is lung cancer. It's quite a wide topic. I'm just touching it and telling you just brief what is really relevant from exam point of view. So predominantly it's caused by smoking and it presents with cough, hemopsis, dyspnea, and cachexia. I don't think I really need to explain these terms. So there is cough, there is blood in the sputum, there is dyspnea, and there is cachexia, that is weight loss and other symptoms, which is because of the cancer, generalized malaise. Patient may have second primary cancers, such as in mouth. So oral cancers, they most of the times they metastasize to lungs. Okay, prognosis is very poor in lung cancer, so it will be having multidisciplinary team approach and it should be dealt accordingly. Then comes this respiratory failure. So as we studied earlier, there are two types of failures, type 1 and type 2. In type 1, there is hypoxia resulting from ventilation perfusion mismatch, which is caused by almost any pulmonary disease and is managed by treatment of primary pathology and by administration of oxygen. So type 1 is because of lack of oxygen because of any of the reasons which causes ventilation perfusion mismatch. And how is it managed? For management, we will administer oxygen and we treat the primary pathology. Next is type 2. respiratory failure. So in respiratory type 2 failure, there is hypoxia as well as hypercapnia, which are resulting from hypoventilation, may have pulmonary or neurological causes, and is managed by treating the cause, careful administration of oxygen, and occasionally artificial ventilation. All right. So these are the important things which you should know about the respiratory diseases which can be found in patient. Most important being asthma, COPD, OSA. So in the exam, you may be given some clinical scenario in which you are given the symptoms of the patient and you may have to differentially diagnose it, or you may be asked to alter the treatment accordingly. And this is included in the next video. So I'll be including the dental aspects of the respiratory diseases in the next video. This is all for now. I hope you enjoyed the video and you learned something from this. And for any queries related to this topic, or if you want me to discuss anything else in detail, I welcome your comments in the comment section below. Good luck, guys. Happy studying.